Yes, so, all right. So great. Trent, if you can kindly advance the slide, that would be great. We kindly note the disclaimer. In addition to, we have no disclosures to report. We just wanted to sort of, our objectives, the list here is long, but I think we wanted this to be interactive, and we wanted to have time for discussion. We wanted to touch base briefly on epidemiology of type 1 diabetes, speak to the impact of COVID on the presentation in regards to DKA, speak to disposition, speak to DKA management guidelines vis-a-vis fluids, monitoring risk factors, alternate treatment options, differentiate DKA from HHS, as well as speak about transition. Canada is a hot zone for type 1 diabetes. These are figures from the International Diabetes Federation Atlas from 2021. Essentially, if you look at the top 10 countries for incidence rates of type 1 diabetes in children under the age of 14, Canada is number 5. And we've continued to be in that top 10 for many years. If you look at sort of how is incidence of type 1 diabetes changing, this is a recent report from 2022 from our sort of Quebec, Montreal colleagues, and it's showing sort of the incidence of type 1 diabetes overall in yellow, as well as the incidence of type 1 diabetes in blue as compared to type 2 diabetes in red. And overall, there's about a 5.2% annual incidence over the past 8 years that they reported. And it was highest in sort of children aged 5 to 11, followed by those aged 1 to 4, which is another additional peak that we're seeing. So we are seeing significant increases annually in type 1 diabetes incidence. In terms of diagnosing diabetes, we wanted to sort of review this, that again, if you are fasting, a threshold of 7 millimoles per liter plus symptoms, including polyuria, polydipsia, and weight loss, will confirm the diagnosis. If you are non-fasting, it would be greater than 11.1, which can be done sort of random or as part of postprandial testing. And if there are no symptoms, then I think that, these tests need to be repeated, and there needs to be sort of further investigations to sort of to evaluate this. In terms of type 1 diabetes, an A1C alone is not a diagnostic criteria, and is meant to be used in conjunction with measures of glycemia and symptomatology. It's important here just to emphasize not to delay treatment. If you have a blood test that shows these values, if patients are symptomatic, especially with the evidence of ketones, they should be referred and further evaluated. You don't need to do further testing. We wanted to sort of touch base upon how patients are presenting, and we've kind of divided this as before the pandemic and after the pandemic, just to further emphasize how the pandemic has sort of increasing the sort of numbers and severity of DKA that we are all seeing. Before the pandemic, remember that many patients do not present in DKA as an initial diagnosis, but patients who do present, we see rates that were in Ontario from 2010 that were around 40% if you were less than 3 years of age, and around 16% if you were greater than 3 years of age. Data from Sick Kids in 2018, prior to the sort of the depths of the pandemic, our rates of DKA at initial presentation was around 30%. When we look post-pandemic, we can see overall in Canada, rates of DKA increase significantly, and also the severity of DKA also increased, so that we are seeing nationally rates close to 50% were in severe DKA with pHs less than 7.1. Globally, a recent meta-analysis that looked at 124,000 children found rates of DKA overall increased 40%, and rates of severe DKA increased over 66%. And the question is, well, why? Certainly there's issues related to access, limitations in primary care, that would have that was, missed or lapsed. There are also behaviors about delayed recognition or accessing treatment. And it's important to recognize that patients with new onset diabetes do not all have COVID. It's actually a very small percentage. When you look, though, there are sort of studies looking at ACE2 receptors related to COVID and the beta cell and immunoregulation. And those studies are ongoing to see if it is a temporary effect or something that is actually quite significant in terms of the etiology of this. And Trent, I think you wanted to speak to guidelines.
Okay, thanks, Fareed. We're going to tag team back and forth a few times here throughout this talk. And I should have mentioned at the beginning, if there are questions, you could either hold it to the end, just so we'll kind of continue the flow. But if you want to throw something in the chat, then we can pause, or you could just open your mic and interrupt us as well. That's fine too. Hopefully we're going to have time at the end for lots of questions. For those who may not know, so TREC has guidelines that they put out every few years, and that's currently what most of our algorithms and pathways are built upon. But the International Society for Pediatric Adolescent Diabetes just put out their recent updated guidelines literally like a month ago. So they're kind of hot off the press, and we're going to kind of go through those guidelines a bit and talk about what's new and what's different. So everyone is familiar with the definition of DKA. You have to have an elevated glucose, and for those Americans who might be in the audience, that's like over 200 milligrams per deciliter. You have to have metabolic acidosis, and you need to have ketones in your blood or your urine. And then we go on to delineate mild, moderate, severe based on where the pH and bicarb are at. And so what is new this year is ISPAD had recommended an elevation in the threshold under which one might be considered acidotic. So the reason for that, I suppose, is that some centers may not have access to a venous pH, and if you just rely on that alone, so the bicarb level is there for those who don't have a pH. And then if you look at some of the studies that have done in the past, you know, bicarb levels of 14, 15, 16, 17 all kind of hover around the same level. And so in the absence of a pH, increasing that threshold to less than 18 was an attempt to try to capture more patients with high blood sugars and ketones who probably have a component of metabolic acidosis who meet the definition for DKA. So what causes DKA? So there's absolute and relative insulin deficiency. So obviously those with new onset diabetes have an absolute insulin deficiency, but then there's those with established diabetes who omit their insulin injections, especially their long-acting insulin, and those who are on an insulin pump that malfunctions, because the way an insulin pump works is it contains short-acting or rapid-acting insulin only. And so when it stops delivering, then there's no long-acting insulin on board. Relative deficiencies from infections, from mismanagement of intercurrent illness at home, especially in the context, say, of viral gastro, where a patient is having vomiting and diarrhea and their blood sugars are running low and parents are afraid to give insulin, so they kind of pull back, hoping to not cause their child to become hypoglycemic without really getting the proper guidance from an endocrinologist. And then they sometimes you can have insufficient insulin when counter-regulatory hormones are increased in the context of, say, severe sepsis or multi-system trauma. In new onset diabetes, they typically are presenting in DKA because of a delay in diagnosis. And as Fareed alluded to earlier, is we've seen a higher rates of patients with new onset presenting in DKA, partly because of access, but also because of not all children necessarily volunteer or are recognized to have polyuria and polydipsia. But also a big one that we see in the emergency department sometimes is that other symptoms can be nonspecific. And there are patients who present more than once to an emergency department before they're diagnosed. And it's because they're coming in with vomiting and abdominal pain, and it's ascribed to an alternate diagnosis. And there's some cognitive biases at play with anchoring and premature closures and stuff. And so just as, you might in a patient with persistent vomiting without diarrhea kind of walk through the differential diagnosis of things like, head injury and increased ICP and toxic ingestion and non-accidental trauma, you kind of need to think of diabetes on that differential. And you should check a blood sugar in patients with unexplained, persistent, ongoing vomiting that doesn't really sound like classic gastro with that combination of vomiting and diarrhea. Also be aware of the concept of euglycemic DKA. So, an example of how this might happen is a patient on an insulin pump that malfunctions and there's a delay in recognition and their blood sugars are climbing and their ketones are climbing. And then, 24 hours later, they finally figure it out and change the site and get the pump going and feel like they're back on board. Meanwhile, they've run into some acidosis, and then they manage that themselves by giving them a big whack of corrective insulin through their insulin pump. And that might force their blood sugar down into a more normal range, but you really haven't corrected the acidosis. So they're still not feeling well and they're still vomiting and acidotic. You can have euglycemic DKA because you're fasting or you're not taking in carbohydrates orally. And then there's SGLT2 inhibitors that can be used in patients in type 1 diabetes, either off-label or through a research project that's going on right now and using these in children with type 1. So really the protocols don't change just because somebody has euglycemic DKA. You still manage them as DKA, except you're going to put glucose into the IV sooner than later. So just leading into a quick conversation about ICU consultation and dispositions, but in 2005, there was a coroner's inquest that mandated province-wide guidelines for pediatric DKA and lowered the threshold to admit pediatric patients with DKA to an intensive care unit. But now, almost 20 years later, we're kind of slowly emerging from this era of very cautious fluids to prevent cerebral injury to newer guidelines around somewhat less strict fluid therapy and a reduced reliance on the intensive care to manage all of these patients with moderate to severe DKA. Andrew Helmers, who's one of the ICU docs, shared this slide with us just to kind of paint the picture, and partly what drove the purpose of this whole webinar with Julia Orkin and her group is around, the landscape and intensive care units across the province and how they're overwhelmed. And as many of you may know, patients who are 14 years of age and older are actually being transitioned into adult intensive care units just to make some capacity in the pediatric centers for the younger children with respiratory illness. So we don't really need to bring all of these moderate kids with DKA into an intensive care. And certainly right now, capacity-wise, we really can't. So when should you call the intensive care? Certainly children with severe DKA, like a pH of less than 7, a bicarb less than 5, they should be in an intensive care realistically. But that's not how most kids present. But obviously severe DKA is what it is, particularly in children who are young, almost certainly in children who are under 2 years of age. But you should also think, obviously, with super high osmolality, if you think somebody might have cerebral edema, patients in shock, patients with significant AKIs, and then vascular access concerns, and just a little plug reminder about avoiding central lines in patients with DKA just because of the higher risk of thrombosis in DKA. And if you really need a central line, then try to get it out as quickly as you can. So from a disposition point of view, you want to admit a patient with moderate to severe DKA at a center where you have experience. So either the physician, the nurses, they've had the experience managing DKA. You need to have adequate monitoring and a lab that can support the turnaround of getting labs every 1 to 2 hours as needed. So mild DKA in most cases can be admitted locally under the care of the pediatrician, maybe with support from the local endocrinologist. Moderate DKA can be admitted locally, but could consider transfer to tertiary care. And just because they're coming to a tertiary care doesn't mean they need intensive care. And even those with severe DKA at our center, some patients with severe DKA are getting ICU consults and are being managed in the emerge or on the ward for 6 to 12 hours until they kind of get out of that severe state. and actually never physically make it into the intensive care. So obviously that's a conversation with the endocrinologist and the intensivist. But the point of this slide is to say, not all kids need to come to a tertiary care center anymore if you have good support and lab access. So, when we look at the protocols, the most common omission in the care of children presenting with DKA is just not using the protocol. So people need to know that they exist, how to access them, following the guidelines, speaking to an endocrinologist where needed. And most of the time we can stay out of trouble. The purpose of the initial fluid bolus is, unlike in patients with sepsis or hypovolemic shock or trauma or whatever, the purpose of the initial fluid bolus in DKA is really not to restore euvolemia. It's to restore end organ perfusion. That's to improve renal clearance, to treat hypotension and significant tachycardia, but you really don't need to chase mild to moderate tachycardia once you've completed that first fluid bolus and you're getting into more of a maintenance phase of care. A reminder that people tend to underestimate the amount of volume deficit in DKA, and just as a general guideline, it's sort of 5 to 10% of the body weight, depending on mild, moderate to severe. The current guidelines based on 2018 are that you give like a 10 mils per kilo bolus over a half an hour, replace deficits over 2 days, add your maintenance, rehydrate with normal saline only, and then your sugar and potassium added as needed. Well, what's really new with the 2022 guidelines is the initial bolus can be a bit more generous. You can do 10 to 20 mils per kilo. You can do it a little bit quicker, over 20 minutes. You can replace the deficits over 24 instead of 48 hours. And the sodium content for your maintenance fluids can range. And you don't have to use just normal saline. In fact, I might argue that you shouldn't just use normal saline. There is a statement, if you actually read the ISPAD guidelines, there is a statement, one of their key statement claims is this sentence: promoting a rise in serum sodium during DKA treatment is no longer considered necessary. It was a bit of a confusing sentence to me, and it took me a little while to understand it. But essentially, the serum sodium level should naturally normalize as the acidosis improves with therapy. But the continued use of 0.9 normal saline can cause iatrogenic hyperchloremia and a hyperchloremic metabolic acidosis. And therefore, it's actually maybe preferable to switch to 0.45 NaCl after your original initial resuscitation. A PCARN study by Cooperman showed that there was really no noticeable or significant difference in the neurological outcomes when patients were given 0.45 versus 0.9 as a maintenance solution. And their conclusion was that 0.45 is an acceptable solution for maintenance, and it's not going to contribute to an increased risk in cerebral injury. And so the thinking now is more around choosing a 0.45 sodium chloride more to prevent the high chloride than it is about promoting the low sodium. Hopefully that's clear. It took me a while to wrap my head around that statement, but I think I've explained it okay. So just moving on to insulin therapy. So the serum half-life of IV insulin is 3 to 5 minutes. So you reach a steady state pretty quickly. And so there is never an indication to give IV insulin loading doses because, one, it just doesn't improve outcomes. And two, is it creates the potential for problems with rapid drops in your glucose and your potassium and your osmotic pressure. And I think there is potentially an association between loading doses of IV insulin and being a risk factor for cerebral edema. We always start with our 0.1 units per kilo per hour, but a reminder that's always after you've done your initial starting fluid replacements. So this is after you've given your bolus and you've started your replacement, and typically it's about an hour into your fluid therapy. Usually we use regular insulin, but to be honest, you don't have to use regular insulin. You can use any rapid acting analog insulin as your IV insulin product. You can Humalog, NovaRapid. They have the same half-life intravenously, even though they might be different subcutaneous. The reason why we use regular, honestly, is just cheaper and everyone's familiar with it. But in a pinch, you could easily substitute those. So are there any questions before I transition over to Fareed, or we can just keep going and folks can interrupt later?
I think there's just a question about the guidelines, and I think I posted a website that they're going to be going on there very shortly. They just have to be, they're published in a journal, and then all of the guidelines are going to be posted once they're all available. So apologies that they're not freely available as yet, but I think they're going through the proofing stage and those other things.
Yeah, Fareed, if you have access to U of T, like if you're on faculty at McMaster or U of T, so I actually got a hold of them through my admin assistant who got them from the library because the U of T has access. So I access them without paying for them, just through my association with the university.
Yeah, so I think we wanted to also I think we talked a little bit about fluids. We talked about sort of what in terms of looking at your sodiums, as well as sort of insulin administration. I wanted to sort of also speak to a little bit about electrolytes and ongoing monitoring. With regards to potassium, I think the recommendation is to add potassium to the IV fluids once the levels are less than 5.5. They do speak about using KCl, but on a subsequent slide, we can make some further suggestions because, again, I think of the concern about a hyperkalemia. With hyperkalemia, if the potassium is elevated, the recommendations are to defer potassium treatment until urine output. There is we don't see usually significant AKI in these patients, but we do know that many of them will have maybe mild to moderate with elevated creatinines. Most of them present with polyuria polydipsia, so the urine output component is usually well established. Just also to emphasize that bicarbonate administration is not recommended unless you're looking at patients who are having, cardiac contractility issues, and so it's not routine and would not be something that you would be using in terms of this. The orange boxes are from the TREC guidelines, and just reminding everyone what to do with IV fluids. And also in the orange box is just reminding us all about what is required on an hourly basis to evaluate blood sugars, very close ins and outs in terms of fluid status, neurovitals, as well as heart rate, and blood pressure evaluations, and every 2 to 4 hours, monitoring of electrolytes as well as venous gases, in order to ensure that we are keeping to the protocol. Thanks, Trent. What do you expect? Well, we would expect the glucose to improve and to start to normalize. As one would expect, post ball volume expansion, once you've given a bolus, the blood glucoses are going to fall precipitously. But once you are beyond that stage, we want to have a nice and steady change in the glucose concentration and keep it to be less than 5 millimole per hour. And once you get to around 15 millimoles per liter from a blood glucose perspective is when we would be adding dextrose into the IV. This table is meant to show that if there is a precipitous drop, and you're at the 15 level, D10 would be recommended. Whereas if it's slower, you can get away with D5. What is done by the pediatric transport teams and what do we generally use on the wards is D10, because it just allows us a little bit more flexibility in terms of what we're, in terms of, not having to change bags all the time. So it can allow a little bit more fine tuning. In terms of changes to the administered insulin infusion, that is done on the basis of the acidosis, what's being shown with your blood gases. And once the pH is improved and you're about 7.15, you can decrease the rate from 0.1 to 0.05 unit per kilo per hour. And you're expecting the acidosis to improve. And sometimes there's a situation where we run into from a troubleshooting perspective, it isn't improving. We had a case like this, I think, even this weekend, where there's a younger patient, the acidosis wasn't improving, and you kind of went through that thought process of what could be, contributing to the fact that there's just been a plateau in this correction. So it's important then to think about, well, where the insulin, was the insulin made properly in the bag? You also have to recognize that insulin adsorbs to plastic tubing. And so if you make a bag of insulin and it's not primed through the tubing, it may not be sort of getting there in an appropriate time. So making sure that that step is carried out is also important. Thinking about other causes that may be contributing in terms of infection, and sort of other sort of reasons for, an increase in acidosis that would be also from a prevention standpoint important is also worthwhile to think about. So I think it's important to sort of consider some of those issues. We wanted to sort of talk about the two-bag method, and people may be very familiar with this who are on the call. The idea is that you have sort of a bag of saline that has no glucose in it, no dextrose in it, and then you have a bag that has dextrose, and in this case it would be D10. And the idea is that, you would sort of use these bags and wire them together, and it would allow you to sort of very fine tune the glucose and the fluid without having to always change bags, and sort of reduces, I think, burden related to sort of some of the nursing components we're looking at. While the guidelines speak to about KCl, what is sort of recommended here, I think in our ICU, is they tend to use potassium acetate and 20 millimole per liter of potassium phosphate. It does allow you to sort of move away from the hyperchloremic metabolic acidosis that we often see in this setting, and also that can also impact sort of the resolution in terms of your anion gap if you are seeing hyperchloremia. So this is, I think, a nice way to do this. We often do see sometimes we can see low phosphate levels in these patients related to the osmotic diuresis, so it can sometimes help with that as well. And generally, you can this was sort of a suggestion made that, if the blood sugars are greater than 15, all the fluid's going to be coming from the normal saline bag with the potassium replacement. If it's 10 to 15, you can take half and half. And if you're less than 10, you're going to be running it sort of mostly from the dextrose bag. And just to remind ourselves about the insulin drip, and thinking about initially starting at 0.1 unit per kilo per hour, and then transitioning once you have an improvement in the acidosis by reducing that rate to 0.05. Again, this is all done in the context of hourly blood sugar checks. We wanted to also touch base a little bit about subcutaneous insulin. And this has sort of come out in lower resource settings, as well as in the settings of the fact that, not all non-severe DKA requires IV insulin and a full DKA protocol. There are episodes with sort of elevated blood sugars and large ketones in sort of short duration. And this often happens with patients with existing type 1, patients who come in frequently. And this is an option that we sort of are doing more frequently related to management. And they can be managed with subcutaneous insulin without having to run an IV insulin infusion. So we wanted to sort of share sort of a subcutaneous insulin protocol that would be helpful. And as part of that, we've included language from the ISPED guidelines, which talk about circumstances where you can't do a continuous IV insulin in administration. And in many places that can be related to, a ward or a unit or, an emerge, although unlikely, in patients who are uncomplicated, mild to moderate DKA. And in this case, you can use subcutaneous insulin using the agents that we've listed below every couple of hours. And this is safe. And this is as effective as IV regular insulin infusion in these instances of an uncomplicated, mild to moderate DKA. In terms of an approach, I think it would be worthwhile to consider this if you've had patients who've completed the initial initiation of fluid and the bolus in the emerge setting. Remember, the insulin is given subcutaneously. We want patients, again, to be mild and not have significant dehydration, have sort of intact neurologic status. Their pH should be greater than 7.1. And you also want to ensure that all the monitoring that we recommended in terms of Q1H blood sugars, as well as venous blood gases every 2 to 4 hours, are also being carried out. It's important that the patient isn't sort of an ICU kind of patient for some of those indications that Trent had spoken to. After you give the IV fluids, you can give a dose of 0.15 units per kilogram per dose. You can use that every 2 hours. And it's important that as a part of ongoing monitoring, that dose can be tapered if you are seeing blood glucoses drop to 0.1 and even up to 0.05 units per kilo per hour every 2 hours until the DKA has resolved. And again, this is where we're sort of happy to sort of hear from, here, because this is newer, we're happy to sort of speak with people who are looking at doing this and look at it, I think, as a viable way to manage some of these patients. Trent, did you want to speak to cerebral imagery?
Sure, thank you. Children are at a higher risk than adults for developing cerebral edema. We're kind of getting a little bit away from the language of cerebral edema and starting to talk more about DKA-related sort of cerebral injury, ranging from mild to severe. Remember, your warning signs and symptoms of cerebral injury, the, progressive headache and vomiting, the bradycardia, the decreased level of consciousness, all that kind of stuff. The reason why it's important to be very sensitive to the warning signs is, although the incidence of clinically apparent cerebral injury is relatively low, like less than 1% of your patients with DKA, the mortality is really quite significant, and it's a challenging complication to recover from. So the risk factors for cerebral injury, originally the injury was thought to be caused by a rapid administration of fluids and changing osmolality, but more recent evidence suggests that cerebral hypoperfusion and hyperinflammation play central roles in the pathophysiology. And it really correlates more with the degree of dehydration and hyperventilation at presentation, and not so much with the initial osmolality or osmotic changes during treatment. So, some of the risk factors, like younger children, patients who have new onset diabetes because they've had a delayed presentation and they've sort of been developing into more moderate to severe DKA by the time they get diagnosed, patients with longer duration of symptoms or more severe acidosis, severe dehydration. So there is in the TREC algorithm and guidelines, obviously, some recommendations about how to manage the cerebral edema and to prevent the injury. If this is obviously a reason to be admitted to an intensive care, so be sensitive to it. And when you're concerned, obviously reach out, and that's a patient where you want to kind of intervene and transfer as soon as possible. I'm going to switch gears slightly and just remind people about hyperglycemic hyperosmolar states. This is usually a problem of patients with type 2 diabetes, frankly, typically more an adult problem, but you can see it in children, and you can see it in children with type 1 diabetes in a mixed kind of presentation where we kind of refer to them as hyperosmolar DKA. They have extremely elevated blood sugars and very high osmolalities, but they have some insulin on board, and albeit they're insulin resistant, they don't undergo lipolysis, and they don't therefore have ketosis, and they're not acidotic. What they are is just they have a significant osmotic diuresis and profound dehydration, and they will need much more rapid volume expansion than your patient with DKA, and the rates of complications and mortality are even higher than those of patients with DKA. So these are patients where, the glucose monitor that says HI, glucose over 33, the osmolality over 320. But interestingly, like they might be a little bit acidotic, but acidosis is really not a feature, and significant ketonuria or ketonemia is just not present. So just as a little bit of a table comparing the two, uh, it's really about the presence or absence of the acidosis with such a high blood sugar and such a high osmolality. So in patients with these mixed features of both DKA and HHS, obviously you're going to have to, this is clearly where you're going to probably want to reach out to a subspecialist and get some high-level guidance. But just looking quickly at the management, comparing the two, kids with HHS are going to have a higher estimate of volume deficit. They're going to need more fluid more quickly, even up to 20 to 40 milliliters per kilo. These kids are really dehydrated. They may need a different saline content in their fluid, and you're probably going to replace their urine output. Whereas in DKA, you don't need to be as aggressive with your fluid resuscitation, and you would not usually replace urine output. The timing of your insulin infusion in HHS is, you're probably going to run a lower infusion, and you're going to do it after the plasma glucose has come down by more than 3 millimole per liter per hour with just fluid alone. Whereas in DKA, you're going to use more insulin, and you're going to typically start that after an hour of IV replacement fluid therapy. And finally, just regarding the sodium and HHS, the corrected sodium should remain stable, and an increase in fluid sodium content, and you should increase the fluid content of your IV fluids if your corrected sodium begins to fall. Whereas, as I just spoke to earlier with DKA, you probably don't need to worry as much about the serum sodium level and tinkering with your IV sodium content. I would just, put them on your normal or half normal saline, and then adjust the rates accordingly rather than adjusting the concentrations. Freed?
Yeah, and I think I would also add that, we are seeing this more commonly, the HHS type of picture, and attuned to some of the, thrombosis or rhabdomyolysis. Sometimes they present with multi-organ failure. So certainly these are patients that we want to be very attuned to. So no, that was great. I think we just wanted to speak to, while you've given enough fluid, patients are they have vascular stability, they look pretty good, they have neurovitals which are appropriate, they're neurologically intact, then we want to say, okay, the DKA is we continue the infusion until the venous pH is better than, greater than 7.3. We have a bicarb, which is greater than 18. And we also have resolution of the ketones, right, which would also be helpful to confirm as well. In these settings, we want to ensure that, the patient is ready to eat. We like to do transitions to subcutaneous insulin with meals generally. And that allows us to, dose them with a bit of a bolus insulin, and then get their basal insulin on board. Again, we tend to use weight-based insulin dosing. We use doses of 0.3 units in younger children. We can start at 0.5 units in older children. We might even go a little bit higher in older adolescents. And we want to combine mealtime and more basal insulins around 50-50 when we're using a multiple daily insulin routine. Again, after work disposition, patients are out of the acute setting. It is involving multidisciplinary care teams. We are fortunate in the Greater Toronto area to have multiple pediatric diabetes teams throughout, many of our at Sick Kids, as well as throughout the Greater Toronto area. And just to remind ourselves, we're trying to balance insulin, diet, monitoring, and activity, and that these patients certainly, have, there's lots to learn during that period in terms of monitoring, but there's a lot that they are going through, and I think would do also engage with multidisciplinary care in order to help achieve these goals. And also to remind ourselves that, diabetes has had profound changes in care. We have a whole slew of medications. It's no longer the clear and the cloudy. We have ultra fast and ultra long insulins that run the gamut from Tresiba to Lantus to Basaglar. We have newer treatments to treat hypoglycemia. We now have these intranasal glucagon puffers that can be administered. We have newer monitoring. We have continuous glucose monitors that can test, blood glucose level every 5 to 15 minutes. This allows us to evaluate sort of an overall time in range over a 24-hour period, which are used alongside hemoglobin A1C. These can be broadcasted and shared with sort of parents and guardians for sort of monitoring, in addition to our clinic, where we sort of upload these when they come in for their clinic visits. We also have newer insulin delivery systems in terms of pumps. We have some newer closed loop pumps that are hybrid, that work in the background and are also very sort of improving A1Cs, and they're including automation and predictive algorithms that allow patients to sort of maintain euglycemia. We wanted to sort of briefly talk about this as sort of an updated figure from the latest 2022 guidelines by ISPAD, and it's meant to sort of share the idea of diabetes care being a spectrum, that we have continuous glucose monitoring, which is important in trying to keep time in range around 70%. We also have, A1C targets that we are aiming for. We want it to be less than 7%. We want to keep our patients to have blood sugar levels 4 to 10, 4 to 8 pre-meals would be ideal. But it meant to sort of say that, these targets are important, but they can be sort of achieved through multiple ways of monitoring and target setting. And I think lastly, we wanted to sort of, end upon the fact that, at the end of this whole process, this idea of what we're trying to achieve overall is a quality of life, and DKA may be their initial sort of presentation and their initial recognition of having type 1 diabetes. But overall, we're really trying to sort of, couch this and bring this into sort of recognizing psychological health of the patient and family, which are also part of the guidelines. We also know that the experience that, patients and families have during their initial diagnosis is key to often their, how well they engage with their diabetes long-term. So having sort of, appropriate and transparent counseling with the initial emergency team, as well as their pediatric and pediatric endocrine sort of contacts, is also key. And I think in the end, this is Trent had kindly put this in at the end to remind us both that this is the end of the slides, but also hopefully the end of finger poking when we go into sort of newer technologies. Is that what you're aiming for, Trent?
Yeah. So one of the, with the new Dexcom G6, right? Like they no longer require calibration, and they're good for, up to 10 days or so. And so there's children today being diagnosed with diabetes who go straight to CGM, who really just don't have that same experience of doing, 5 to 7 to 8 finger pokes a day, tracking their ups and downs. And at camp, we would normally go through about 1,000 finger pokes in a day at camp, 1,000 per day of finger poke strips. And with 90% of the kids being on CGM, the only ones getting finger pokes now are the kids who are not on a CGM, or those who are having repeated lows where you need to kind of figure out, how to intervene. But it's changed the whole landscape. And now they're monitors that have devices that have high and low threshold limits that, alert the kids to when they're going low, or when they might go low in the next 30 minutes, or when they might go high in the next 30 minutes. And it's just, I feel like I'm not needed as much at camp anymore. It's all the technology's replacing me. So we'll open it to the field. If there's no questions, that's okay. The whole point or purpose of this talk was to try to give a brief update in the context of perhaps people being asked to manage patients with DKA on their wards, where perhaps they might have previously been biased towards sending them out to a tertiary care center. So if there's any kind of like nuanced questions or issues that have come up that you wanted to fire, we've got like 10, 15 minutes. Freed is the diabetes DKA expert, so I will lean on him more than me, but happy to open up to any questions. Or will we get radio silence? Otherwise, I'm going to make Julia Orkin turn on her mic and ask questions. Some Jeopardy music. Okay.
I know. I
No
think we
questions.
look in the diabetes sphere, we feel like we are busier than we've ever been, right? And I think the numbers back that up. And you know, again, this is also sort of, again, how do we work together with, you know, with our community partners? And we, you know, we're also fortunate that we have pediatric endocrinologists working at community centers as well, who, you know, are also can hopefully, you know, help with, you know, people at their local institutions too. So I think that's what we're trying to do, is sort of help with this sort of community of practice. And the subcutaneous insulin is sort of a newer, we've been doing it for a few months now, and it actually has been, it's worked quite well in those patients who are moderate, mild and moderate, and we're able to sort of get away without having to use an infusion. But it's not for everyone, and we wanted it to be sort of done under sort of specific circumstances. So I think that was sort of something that we also wanted to share.
I saw Krista turn on her video. That means she wants to say something.
Hi. Oh, my video is working. Hello. No, I just wanted to thank you and for everyone online for participating today. Really a fulsome overview of DKA. And I know our community partners are meeting these kids at the door of the emergency department, some inpatient pediatrics, as well as occasionally in their ICUs for the over 14-year-olds. Just appreciating so much that you both, you and Fareed, brought your expertise to the Connected Care webinars this week. And we will record this, make it available, and look forward to meeting any other gaps in terms of topics and needs that the community hospitals may identify for us. So don't hesitate to let us know. Thank you.
We'll hang out for a minute just in case somebody does want to pop in and ask a question, maybe with a smaller audience, in case they're feeling like they don't want to speak in front of too many people.
I think Amanda, did you have a question?
Yeah, hi. I just wanted to ask, I don't think it said in your slide, if you're treating mild or moderate DKA with subcutaneous insulin, if they're not on an insulin pump and they haven't taken their long-acting insulin for however long, would you give that plus the rapid insulin?
I think, you know, the patients, if they're coming in with, you know, blood sugars that are elevated, we would manage them with that same dose and continue monitoring them every hour. The pump, so we were talking a little bit about this. So when in an insulin pump, often when you have elevated blood sugars and patients are on insulin pumps, you know, we look to sort of the issue is that whether there's a pump malfunction and whether or not either the cannula or if they're using an Omnipod, which is directly attached to them, there's been some issue with an interruption in insulin administration. So in those cases, we would sort of request that they do a site change, okay? And we can sort of maybe try to use that ongoing in conjunction with our therapy. And during that site change, we would give a dose of subcutaneous insulin. That's what we recommend when they call into us, right? Often for after hours care. The issue is that you don't want sort of, if they're running on their sort of high sort of basal rates, if the rates are very high, then that might sort of combine with your subcutaneous insulin, right? And potentially sort of drive them a little bit lower in that case. So you can sort of run them on sort of lower rates, potentially not their kind of corrective rates, and see after 2 hours how they're doing. And if you're seeing a nice resolution, then you could sort of also increase their basal rates and include sort of corrections as part of that.
Fareed, maybe I think if I'm understanding Amanda's question, I think when you talked about the sub-Q option, the understanding was that that was kind of like in substitution of an IV insulin infusion as like an alternative. So if somebody's being admitted for DKA and getting sort of serial sub-Q injections in place of an IV insulin because you don't have access, the question is do you include the long-acting insulin at the same time, or do you wait and just use the sub-Q every hourly until you're out of DKA?
Yeah. So, sorry, I misunderstood sort of from an illness management guideline versus the DKA. So my apologies, Amanda. No, we wouldn't be giving them their long-acting insulin. We would just be treating them with subcutaneous short-acting insulin.
Is that right, Amanda? Is that what your question was?
Yeah, I was wondering essentially if their normal insulin is Lantus plus Nova Rapid for meals. let's say they've missed their Lantus for, a couple of days. Should you give the Lantus and then also follow your protocol for the sub-Q insulin to correct the DKA?
No, we wouldn't put the Lantus on board. We just handle it with the sub-Q and then try to restart the Lantus when they're ready to transition. I was going through some nuances related to pump therapy, which perhaps, which again, we do face, but when someone's in DKA, we tend not to use, we're not going to be using their pump because it won't be reliable, right? We'd sort of switch to the insulin infusion or just the subcutaneous short-acting insulin. If they're in the illness phase and we're sort of, we can fix it in the background, and then when they often call us or call their community endocrinologists, we can sometimes do a hybrid and a combination therapy to try to correct them over time. And in that case, we would use their pump. But if they're presenting with Flora DKA, we wouldn't be using it.
It's a good question, Amanda. Great. I mean, this was a talk on DKA, but there's like, my gosh, Breed and I could probably spend an hour giving a whole nother talk on intercurrent illness management and non-DKA, hypoglycemia, kids who come in on insulin pumps with problems, kids who are MPO, getting an appendicitis workup, who happen to have DKA, and like there's a whole, other side to sort of DKA illness management that's not touched upon on DKA, but
and also I think we didn't, the idea of prevention, right? And we try to sort of certainly look at that, and also, I mean, these patients, and I think Trent sort of spoke to, looking for associated illness, infections, sepsis. Right. I mean, not all of this can be necessarily ascribed always to diabetes, but looking if there's additional foci that they may require antibiotic treatment and other things as well. So that's another piece, of course, that, was sort of referred to, but maybe we could emphasize as well.
Yeah, I also find a lot of people get a bit, when kids come up into triage and they have a high blood sugar and they're on an insulin pump or even on injections. And then the idea is like, you got to check the ketones, right? Just because a patient has a high blood sugar doesn't mean they're in DKA. Just a reminder that before you start doing blood work and gases and sticking in IVs, like, do they have ketones? Yes or no? Because if they don't have ketones, they just needed more insulin. I see that mistake kind of commonly where people overreact, and just because a child has a blood sugar, people think, oh my gosh, there's a child with DKA. I was like, hold on, you need the A. you don't have the K and the A. So I happy to take more questions, but sounds like folks are feeling okay. If you do have other thoughts that come up, you can email us or email Fareed. And then, of course, anytime you have a child that's being admitted, if you don't have a local endocrinologist on call and you're in a community center without that kind of support, then, depending on your catchment area, McMaster, Toronto, London, then you reach out to the tertiary care center for that support, and then they'll guide you accordingly.
Grant, I can't post your number in the chat.
Not my personal cell phone number now, but
okay, but yeah, absolutely. We're again, if there's questions and we can help with, certainly. I think it's important to reach out, and we just wanted to provide some sort of background, and hopefully it was informative and useful.
Oh, there's a hand up. Ooh.
Hi there. Thanks so much for the talk. I just have just want to go back to the using half normal saline after your boluses, because I think that's going to be a practice change for a lot of us. And I think we need to be a little emboldened by maybe what you're doing in your Emerge, Trent. So if a child is, not presenting with any neurological symptoms, are you pretty routinely now, or can you see yourself on the 0.45?
Yeah, so to be honest, this is kind of like an inpatient phase of care issue, right? So in the Emerge, I would just keep it simple. Start with normal saline, give your 10 or 20 mils per kilo bolus, calculate your deficits, talk to endocrinology, put in your orders for like Q1, glucoses and labs, and get things started. You're going to be writing your insulin infusion to start an hour after bolus. And if you want to just, keep them on normal saline for the first couple of hours of therapy until their inpatient bed comes available, I think that's totally fine. When they get admitted to the inpatient unit in consultation with endocrinology, at that point is when they start doing some tinkering, right? Well, let's add the glucose, we'll add the potassium, let's drop the sodium content, and they start to kind of really get into the finessing of some of the electrolytes and sodium and other electrolyte concentrations. But in the emerge, if you're an emerge doc, I wouldn't say that in the emergency department, we're the ones that are dropping the sodium to half normal. And I don't think it's that important to do in the first hour or 2 or 3 of care. I think it's really when you're replacing 10% volume losses over the next 24 to 48 hours, it doesn't need to be all normal saline.
Okay, thank you. Yes, I'm a general pediatrician, so I sort of receive them from the emerge and then
yeah, so by the time you receive them and when you go to put in your inpatient orders, like several hours into their care, sure. I mean, you're going to have had a conversation with endo, I'm assuming, at that point. And then either you or they would prompt the question, like, do you want me to continue normal saline? Would you like me to drop them to half normal just, because of the new guidelines? And Fareed, I don't know if that's a standard of practice now for you, for all of your patients.
And it's a great question. I mean, we sometimes, the PCARN study that, we're alluding to that sort of demonstrated this with the New England Journal of Medicine, which, last time I heard was, pretty widely read. But there is sort of this, there's still a lot of resistance to sort of using the 0.55 normal saline. And if you look at sort of the 2-bag technique, I had 0.9 in that, right? We showed it as 0.9. We tend to, within our ICU, and often, when they come outside, we may try 0.45, but we still tend to continue with 0.9. Normal saline, which tends to be our fluid of choice. If we're dealing with sort of other issues, sometimes we see combined, sometimes patients come in with hypernatremia, right? In addition to hyperglycemia, and therefore to the tailoring of the fluids as sort of Trent has spoken to. So it tends to be sort of more of our fluid to go to than the sort of the half normal, although I think that's going to be a practice change that as we sort of move on, we're going to try it more. But it tends to be something that we do in the latter stages of our sort of fluid replacement as opposed to the earlier stages that you guys were discussing.
Thank you so much.
Yeah, cheers.
Great. Well, it's 5 o'clock. If there's no more questions, I guess we can end there.